on gastroenterology. Actually, this was my topic in my PG also. I was working on dysphagia in my PG days. So Dr. Peeyush Kumar, I will introduce him. He is a very young, budding gastroenterologist, graduate from UCMS. Most of us know how prestigious it is. And then postgraduate and DM from Cmes. He is presently working as consultant gastroenterologist and hepatologist at Fortis Escorts Hospital of Clark. He also has his own very nice center by the name ProCare Super Specialty Clinic. So topic for today is of course different from what we have been listening day in and out, maybe for 20 CMEs, every time diabetes, weight loss or cardiology, this time is different, especially new term. Actually this necroinflammation was not a common name given earlier. Necro means dead. So dead cells causing inflammation or being dead due to inflammation. This he will tell us in details what is the exact pathophysiology, the dead cell causing inflammation or inflammation is causing dead or it is going on vice versa and a never-ending cycle. Human body is made up of, roughly 33 trillion cells, almost debt on US. This much is the debt, $33 trillion is the debt on USA. Anyway, there are at least 200 types of cells in our body. Cells keep on dying on a programmed cycle, apoptosis, but there are other deaths other than apoptosis, necroptosis or death due to inflammation is on it. So I will not take much time. I just invite him for a short talk and very, very long interaction. Welcome here.
Thank you, sir, for the wonderful introduction. Upfront, I would like to thank Team Abbott for this opportunity and the Physician Forum of India for your esteemed presence here, all of you being here. Thank you so much. So, I'll be talking on this topic which sir has already introduced, necroinflammation and treatment in liver diseases. So, upfront let's talk about, firstly, what is necroinflammation? As sir has already discussed, it is combination of cell death because of necrosis which could be induced by any of the processes, any of the etiologies like alcohol, viral, fatty liver, drug induced, which sets in a pathway, a cascade of inflammation, which then takes it towards the progression, fibrosis, and then ultimately cirrhosis. So, as we talk, firstly, what is the burden of CLD in India? So, this was a study from AIMS which showed, it was a systematic review and meta-analysis which of nearly 6,000 patients were observed in this, and the predominant etiology observed was alcohol followed by fatty liver and then viral hepatitis, the recent trend. This another study from Eastern India demonstrated the same thing, alcohol most common followed by fatty liver. So there is a rising burden of chronic liver disease across various etiologies in India. The burden of liver disease in India is significant, alone contributing nearly 20% to the 2 million global liver disease related deaths in 2015. Etiologies are different, but once the etiology leads to the inflammatory cascade, the progression remains the same. So what is necroinflammation? Necrosis is a continuum in the liver disease, ranging from, it can be apoptotic acidophilic to massive hepatic necrosis leading to acute liver failure. So it plays the key role in assessing the severity of liver injury accompanying alcohol. So when we talk of it, we look at the various etiologies, whether it is Hep B, Hep C, Western diet, alcohol, It initiates the liver injury. If the insult continues, then it causes apoptosis. It causes the death of the liver cells, which then leads to production of pro-inflammatory cytokines, activating the macrophages, the Kupffer cells, driving fibrosis through transforming growth factor beta and PDGF. So this activates the fibroblast. Once the fibroblast is activated, it progresses towards the fibrosis from the inflammatory cascade. So once the cascade is started, it then goes from inflammation to fibrosis, irrespective of the cause of etiology. So this is the main driving force which is causing problems of fibrosis and cirrhosis ultimately. So why this matters? Because this is the ultimate process which is going to determine whether the patient goes for a transplant or can be managed medically. So these signs which tell us about the necroinflammation, the inflammation part of liver disease, are the blood reports, the AST, ALT. So when you see these patients who have inflammation have significantly higher AST, ALT as compared to those without inflammation. So when we talk of inflammation, we also talk of drugs which can act through anti-inflammatory pathway other than controlling the etiology. Other than controlling the etiology, we are talking about UDCA, which works through anti-apoptotic, choleretic pathway and altering the bile acid pool, making it more hydrophilic and preventing the damage of hepatocytes and cholangiocytes from the hydrophobic bile acids, and eventually preventing the mitochondrial injury and reversing the fibrosis. So this is what UDCA does, the drug which I am sure all of us has written and been writing for long. So UDCA, it is secreted through the canalicular membrane of the hepatocyte. Once it reaches the cholangiocyte lumen, it is reabsorbed and then is re-released through the basolateral membrane into the hepatocytes. During this cycle of cholehepatic shunt, what happens is it releases the bicarbonate ion through this ACE, which is the transporter, anion exchange transporter. During this bicarbonate ion makes this bile more hydrophilic and more conducive, prevents the damage from the lithotomic secondary bile cells. So this is the mechanism, and once the bicarbonate increases in the lumen, in the canalicular membrane of the hepatocytes and the cholangiocytes, it prevents the phospholipid dissolution, the mitochondrial injury in these cells. Then dosing, when we talk of, it is usually given from 10 mg per kg to 25 mg per kg in varying doses. Long-term data supports its use in a few of the conditions which I will be talking about in detail. And it's a safe and reliable drug, but it has to be given with caution considering the interactions with various other bile acid sequestrants, antacids, OCPs, and its levels are also affected by drugs like dapsone, cyclosporine, fibrates. So let us talk about some of the evidence. It is not a robust evidence, but a very little bit we have. Elite study, a retrospective study of only 50 patients of MASLD, which were followed up for ALT, AST, ALP and GLT improvement after giving UDCA, saroglitazar, vitamin E. So UDCAs showed better improvement than all the rest of the drugs in all the 4 parameters. And when we talk of its uses, it has also been given in drug-induced liver injury. Again, very small sample size studies, 15, 27, 71 and 22, but showing some benefit in terms of normalizing ALT, ASTs, the markers of inflammation. And we have all been using UDCA in alcoholic liver disease, so this is one of its study. Single center study with 53 patients of alcoholic liver disease, wherein UDCA was used for 36 months. It showed clinical improvement, biochemical improvement and histological improvement. This was a paired biopsy study. which showed improvement. But again, the insult, which was the alcohol, was also controlled in all of them, so we don't know whether it was spontaneous or UDCA led improvement, but still there is an association, which has not been proven in RCTs. This, another study demonstrating the same thing, improvement in UDCA when it was compared to the herbal medicines in alcoholic liver disease, demonstrated some benefit in terms of reducing the AST/ALTs and conjugated bilirubin. When we talk of viral hepatitis, the prolonged cholestatic phase of AE, UDCA is very commonly used. The mechanism with which it works is it increases the hydrophilic bile acids and reduces the toxic deoxycholic acid and deoxycholic acid, which are driving the liver injury. So how does it cause liver injury? By dissolving the phospholipids and cholesterols in the hepatocytes and cholangiocytes, so which is prevented by UDCA. This is another study for viral hepatitis, wherein 79 patients of acute viral hepatitis B, C, A, E, all the subgroups were randomized to receive UDCA versus no treatment. So herein, use of UDCA showed better AST/ALT inflammatory control as compared to placebo. This is a very old study when the treatment of hepatitis C was not there. So this showed significant improvement in patients who had failed interferon. Today we don't use this drug, interferon. We have better treatment options for hepatitis C, so it doesn't hold much of a promise there. So this is what I have compiled for all of you. How and where we use UDCA and what can be the real indications and how to use it. So firstly, gallstones. I have had many patients with small gallstones, large gallstones, asking about, I don't want to undergo a surgery because I have never had an attack of cholecystitis. So should I start UDCA? So the answer is, I don't know. The thing is, there is no robust data, no RCT, no meta-analysis telling us what to do, but the prospective data from many of the trials have shown that smaller stones, first we have to be very sure that we are dealing with a healthy gallbladder. It is not diseased, patient has never had an attack of acute cholecystitis or had a CVD stone. Once the gallbladder is healthy, then we do an HIDA scan which will tell us about the motility of the gallbladder. If the gallbladder is normally motile, it's not hypomotile, then we look at the nature of the stone. If it is less than 10 mm or better, less than 6 mm radiolucent stone, so then you can give a trial of UDCA, explaining the risk and benefit, that 1 to 2% risk of getting an attack of folic cystitis every year. So this is the only indication at the dose of 600 mg, 300 mg BD, preferably at night time when you are giving it for this indication. Again, not a robust data, but this is what we have. For MASH and MESED, there is a lot of talk about it, and but I'm sorry, the UDLIF team, but there is no clear-cut indication of giving it in MESED or MASH. Yes, you can give it as an adjunct once you have controlled the other parameters and the biochemical markers are not improving. Once you have taken care of obesity, once you have taken care of other factors, there is some role, but not an absolute indication. Alcoholic-related liver disease, simple, there is no much role, no data to support it. And matrix fraction more than 35, you go for steroids. Patient is cirrhotic decompensated, you go for transplant. MDF less than 35, you treat the patient with nutrition. And autoimmune hepatitis, to control, it can be given as an adjunct, but not as an alternative to immunosuppression. Immunosuppression is the first thing. So now coming on to the important ones. PBC-AIH overlap. Autoimmune hepatitis you treat with steroid. PBC is the only proven indication to give UDCA. So considering that, PBC-AIH overlap becomes an absolute indication to treat this patient, because here the problem is with the biliary channel. Here the damage is done by bile acids, which are lithogenic bile acids. So giving UDCA will prevent it. This is all where we use it. So PBC, first line modifying drug has shown significant benefit, a strong recommendation to use this drug. It improves inflammation, it improves transplant-free survival, delays fibrosis, and reduces development of portal hypertension. PSC, it's indicated but at lower doses. Recent data has shown using it at higher doses of 30 mg per kg, more than 25, you might end up causing more trouble, more biliary damage. So use it at 10 to 15 mg per kg. Conditional recommendation, intrahepatic cholestasis of pregnancy, no RCTs. There are RCTs, but no significant meta-analysis to tell us that it is a good drug, but there is a moderate recommendation. We all use it to prevent the damage. It has shown to improve the rates of IUGR, it improves the maternal as well as the fetal survival in cases of IHCP. Delete, it is given as an adjunct. The primary therapy remains stopping the inciting drug. Acute viral hepatitis, AE, prolonged cholestatic phase, patient is having itching, patient is having continued jaundice. There is an adjunct role to prevent biliary damage, which has been started by the inflammatory cascade, but again not a very strong formal recommendation. Wow. Thank you so much. So happy to be having your opinion on this topic.
Peeyush, idhar aa jaye.
Thank you, Dr. Peeyush, for a very short and sweet deliberation. I think it is one of the best deliberations we have had on this topic. And I actually was asking Peeyush ki kitni der ki hogi, kyunki introduction mein काफी time लग गया है और देवेन और नरेश मुझे कहते हैं शुरू करो. अभी कितना टाइम हुआ यार?
सर 8:50.
9:50. I think Deven is traveling with 25 max. You are going back. 8:50 नहीं यार, 9:50 हो गए. So anyway, we have time for interaction. And it's a very interesting topic. Necroinflammation in chronic liver disease. First to my moderator, Dr. M L Kalra sir, to set the context and to set the ball rolling.
Yeah, very nice talk. Just as you were explaining the mode of action, you mentioned about bicarbonate. So, if bicarbonate is effective and useful, is alkaline water also having any benefit in this kind of issue, liver related or gallbladder related?
So sir, when we talk of bicarbonate, it is the bicarbonate levels in the bile. So and I don't think alkaline water would do that, would increase the bicarbonate levels. That is mostly done by the bile acid transporters which are there, the SEBPs, the AE2s, which in exchange of the bile acids, they release the bicarbonate, which is the main thing which prevents the damage from the lithogenic bile. So it's the...
I also have no great choice about that, but I wanted to know from you. You gave so many lists. Majority of them were not so strongly recommending use, but still, most of us, if we don't give patient will take, or he will go for live 52 or something like that. So, suppose a person is a daily alcohol user, and he takes it as a kind of bachav ho jayega. So at least some psychotherapeutic benefit or say placebo effect, is it there?
No sir, I didn't say we don't give it. I also give it, everybody gives it. The thing is, there is evidence-based medicine which says there is some role. But in practical medicine, when we are in the OPD, when we have a patient who has got a disease, he has come to us, and we know that this is not the primary drug which is going to solve this problem, but this will definitely add to his, it will definitely decrease the inflammation. There is a lot of basic science going into this, there is a lot of evidence going into this, but no RCTs because of logistics, because of the type of situations these patients have. Other than that, all of us have been using it and it works, but as an adjunct. So when an alcoholic comes, we have to tell him to stop, we have to control other parameters like fatty liver if he has that, CAM intake, and we are going to use it. UDCA will be used as an adjunct to the existing therapy.
Are there any studies when this is given alone, UDC, and along with vitamin E? So head to head, alone, both of them, or together? Any benefit?
So there was a study which I showed, which was of 52 patients, wherein they gave in alcoholic, in acid, as well as some component of it was also alcoholic, E, saroglitazar, and this, wherein it has shown benefit, but it is, again sir, I would like to say it is as an adjunct, because all of those patients who were in the trial were controlled on their alcohol intake. So first reduce the injury, reduce the insult, and then add a drug which is going to prevent the progression up to fibrosis and inflammation.
Excellent presentation. Excellent presentation, Dr. Peeyush. Just 2 comments. One, when it comes to UDCA, we have found, quite a few of us, adults and pediatricians in clinical practice, that the mindset is that when there's severe cholestasis, then use UDCA to get the bilirubin down. But in many patients we have seen with very mild hyperbilirubinemia and significant transaminitis, UDCA does help. But as you said, there's no controlled trial which has looked at it anywhere. So this is something which is a good opening. I think in India we really need to look at controlled trials of children or adults with significant transaminitis, and usually in hepatitis A you'll find SGOT, SGPT in 3,000, 4,000, with bilirubin only about 4 or 5. In these children, or in adults for that matter, with hepatitis E or elsewhere, does UDCA really help in getting the transaminitis significantly down? This is something we need to look at, and this is an important area. Second thing is that when you talk of necroinflammation, as practicing pediatricians or practicing clinicians, adults, GPs or hepatologists or gastroenterologists, we need to actually emphasize the point that necroinflammation is very well understood among the public, among the parents, when it's an acute liver injury, like an acute liver failure. बच्चा तो या बड़ा तो बिल्कुल ठीक ठाक था, 3-4 दिन में सब कुछ हुआ, एकदम नीचे हो गया. But when there's a chronic disease, there's a sense of complacence कि बहुत सारे problems हो रहे हैं. When the damage happens, especially like, let's say, NAFLD, or even in NAFLD there's a necroinflammation happening, or Wilson's or any other condition. Even there, be it acute or chronic, we must keep a close watch, and the follow-up must be emphasized as clinicians on the patient, that आप महीने में या 6 हफ्ते में जरूर आके हमें दिखाएं. That's all.
Sure.
Dr. Peeyush, wonderful presentation. I would like to ask you some very specific questions which concern my practice. I am basically into diabetes, 90%, 10% physician practice. And I am so grateful to Dr. P.K. Mangla sir. उन्होंने ना मुझे डायबिटोलॉजिस्ट बना दिया साउथ दिल्ली में. वो हमेशा पेशेंट को बोलते हैं he is the best डायबिटोलॉजिस्ट, और अभी बहुत ही एक सीनियर प्रोफेसर ऑफ UCMS के हस्बैंड को उन्होंने मुझे सौंपा है. आई एम ट्राइंग टू डू माई बेट एंड दे केम विद सच अ स्ट्रॉन्ग रिकमेंडेशन कि डॉक्टर साहब आप ठीक कर ही दोगे. ठीक है, तो इट्स ऑलवेज चैलेंज. तो हम भी जब मरीज को भेजेंगे तो आपके पास ऐसे ही भेजेंगे कि आपको नया लीवर लगा के ही भेजेंगे, वो आप चिंता मत करें. ठीक है, तो मैं सिर्फ एग्जाम्पल दे रहा हूँ कि सर कहते हैं कि डॉक्टर मंगला कि वो आपको या तो नया पैंक्रियास लगा देगा या आपको नया कर देगा. ठीक है, तो ये है ना, 2 चीजें होती हैं. जैसे हम डॉक्टर मंगला के पास मरीज भेजते हैं तो हम तो उनको कहते हैं कि या तो वो ठीक कर देंगे या ठीक करवा देंगे. ठीक है, तो वही चीज सर हमारे पे ऊपर भी. सर थैंक यू वेरी मच फॉर सपोर्टिंग मी सो ब्यूटीफुली. माय क्वेश्चन इज diabetes is surrogate marker of fatty liver. Fatty liver is a surrogate marker of type 2 diabetes, which is a surrogate marker of low HDL cholesterol, which is a surrogate marker of insulin resistance. If you see the chain, right? Now I want to ask you that there are a lot of molecules in diabetes like SGLT2 inhibitors, and there are even historical proof of e-lift study of NASH resolution, of fibrosis resolution. What is your take on SGLT2 inhibitors and their role in liver necroinflammation?
Sir, SGLT2 inhibitors, they are good drugs. For use, they induce some amount of weight loss. They definitely bring down our AST, ALTs. But again, and we do use it. As gastros, we do use it if the patient has diabetes. It's a preferable drug if the patient has diabetes with MASH. But when we talk of MASH alone, then the indication becomes a bit low, because now we have drugs which are working on the basic pathogenesis like resmetirom, like semaglutide, even tirzepatide. If the patient is obese, we can give that. So in patients who are that a subgroup which is diabetic MASH, yes, it's a very good drug. We also very commonly use it, and it induces some good amount of weight loss, and given again as an adjunct to the base therapy.
All right. Now you mentioned about semaglutide, GLP-1 analogs. As early as February of 2026, semaglutide was approved by US FDA for NASH and for NAFLD. And the recommendation, I think, has already come for tirzepatide also, if I am not mistaken, but I am not aware whether it has come or not. Now I want to ask you a question. If I have a diabetic who is obese and who has got grade 2 fatty liver on ultrasound, no significant fibrosis on fibroscan, what should be my first drug for this patient? Semaglutide or Urelip?
So if patient is obese, diabetic,
Yes.
and no significant fibrosis.
On fibroscan there is no significant fibrosis, but on ultrasound there is grade 2 fatty liver.
And there is no transaminitis.
There is mild transaminitis, about 106
So
SGOT,
if-
108
So
SGPT.
if there is transaminitis, this is MASH, metabolic syndrome associated steatohepatitis.
This
In
is MASH.
steatohepatitis, the first line drug becomes semaglutide.
So we should give semaglutide.
Yes.
There is no role for Urelip in this
There is
patient.
a role, there is definitely again a role,
Concomitant or
concomitant. It has to be given alongside but the first line drug stays as the base drug which will control the thing which has led to this inflammation. The inflammation part which is ongoing will be controlled by an adjunct like this UDCA or non-UDCA for that
Like
matter.
once the transaminitis settles down, do you stop Urelip?
Yes, I would stop. If I have achieved the goal of the desired weight loss, the transaminitis has resolved, I would not look at ultrasound. If the fibroscan is normal, there is no evidence of portal hypertension, I would stop the UDCA, I would continue the drug till the semaglutide and gradually taper it off, and this is how we follow the patient.
All right. You mentioned about the drug resmetirom. No, it has, I think, now been launched, or it is about to
It
be
is
launched?
there, it is there, it is there.
It's a very costly drug,
It's a good thing it's an oral drug.
but it's a very costly drug
It would cost somewhere around, I think, 6,000 per month.
per month. On top of that,
It is as comparable to semaglutide when we talk of resmetirom.
head-to-head comparison between Urelip and resmetirom. What is your viewpoint?
Again, the same answer. Resmetirom is a very good drug. FDA, there are only 2 drugs approved for MASH. There is a spectrum. We are talking of MASLD, which is just a fatty liver disease. Then there is MASH, wherein we have evidence of moderate to severe fibrosis or inflammation. AST, ALTs are now getting deranged, or the patient has set in a fibrosis. Fibroscan LSM showing more than 8. These,
So you would prefer resmetirom?
if the patient is lean MASH, fibrosis, without diabetes, without obesity, resmetirom becomes the first choice because it's a specific drug.
Kindly tell us about resmetirom. What is the brand name? How long to use? What is the dose? How frequently?
Remash is the one I know. I think they would have launched more, but Remash is one I know. So it is a thyroid hormone, you all would be knowing it. Thyroid hormone beta. There are thyroid hormone receptor alpha and beta. Alphas are there everywhere in the body, heart, kidney, heart, bone and muscles. Beta is specifically in the liver. So what is it doing? It is like treating hypothyroidism specifically in the liver.
Wow.
So,
Wow.
so now we are just inducing beta oxidation through thyroid hormone receptor beta. So which is going to dilute the fat, which is going to control the MASH, but it is not going to act on obesity.
Now, they study something else. We came to know that if fibrosis occurs, it is irreversible. In NASH or in MASH, has fibrosis set in or not? Kindly elucidate.
MASH is, so there are grades of fibrosis, F2, F3, F4. F4 is what we call
Is there
cirrhosis.
fibrosis in MASH or not?
MASH is F2, F3 fibrosis.
Resveratrol is supposed to be reversing MASH.
Yes, it will reverse. It will reverse F2, F3
So is
fibrosis.
it not antagonistic to our understanding of pathology, where we said fibrosis is not reversible?
Sir, fibrosis is not a single stage. It is a continuum.
Okay.
It is like from early fibrosis to late fibrosis. When we go to
So
a
early
stage-
fibrosis is reversible.
Yes. If you go to the
Cirrhosis is not.
Cirrhosis is not reversible. It is going to improve with time, but not reversible.
Cirrhosis can be improved with resveratrol.
Cirrhosis, there is no indication. When we talk, because
There is no indication for resveratrol in cirrhosis.
if the patient has now developed portal hypertension,
Okay.
there are varices, there is ascites, he is decompensated, then
Yeah.
you have lost the train. It
Okay.
is not going to help him much. But if there is F2, F3 fibrosis, where fibroscan is showing 8 to 12, this is the window where you use it. More than 12, there is no much.
I would also like you to elucidate the role of pioglitazone. This was a wonderful drug that, PPR gamma agonist that we came to know helps with fatty liver, and we were told that if a patient of diabetes is there alone with fatty liver, use pioglitazone. So you take on that.
It was one of the first drugs which was introduced, the pioglitazone. I have not personally used it, but the data is good for its use in diabetic, I think, and it shows some amount of reversal, but it is not showing reversal of fibrosis.
Any head-to-head comparison between urine and pioglitazone?
No, I don't think so. There is any utility.
Right. For the benefit of so many educated people, learned people in our gathering, there is a great drug that was launched by Zydus many years ago called saroglitazar. What is the role of saroglitazar in fatty liver, in MASH? Please elucidate.
Saroglitazar is only approved in India through a trial which was just an abstract. So it is not an FDA approved drug. It works, but the trial which led to its
Yes or no?
So it's difficult to say yes or no, but it improves the.
Do you use it?
I don't use it.
All right. That's enough. We will not go into details. Dr. Saurabh sir.
Hi sir, I'll just ask you a very practical scenario. A grade 3 fatty liver with CAP 320, no fibrosis, BMI around 26, 27, no transaminitis in liver, LFT reports. What is the next step you can do?
Then it has to be individualized. If this patient is obese, there is no indication from
It's
MASH.
26, 27. Normal Indian
There is
average BMI.
There is no MASH. You're talking about MASL. So MASL, there is no indication to give this drug. I would not go on to the drug first. First is a lifestyle modification, which includes again diet, exercise, every other thing, which is the bread and butter. Then, if the patient justifies this use of other GLPs, not for the indication of MASH, like he is overweight or obese with osteoarthritis or has got any other complication, morbidity associated with diabetes, then you might end up giving tirzepatide, but I would not give semaglutide unless the patient is having some fibrosis or some MASH.
Say it's a lean patient, say around 21, 22 BMI. And they come with grade 3 fatty liver. It happens quite a lot nowadays. Now what to tell them? They tell that how I can lose weight now.
So there is what, see, there is no recommendation per se. I can't put them on semaglutide because they don't have fibrosis. They don't have inflammation. I can then ask them to go for the next step if they agree. It has to be individualized. It would be a liver biopsy. That is the ultimately invasive, But that is going to tell you that they have
an autoimmune phenomenon.
inflammation or not. If the biopsy has no inflammation, it is not liver. Then they are stuck with lifestyle modifications. You can help them if they justify for the use of GLPs through other indications, but not for MASH first.
Now, another scenario is there when we use UDCA in cirrhotic patients, a proven cirrhotic patient. Do you feel that is there a lifetime like once cirrhosis has happened? What is the indications that you stop an UDCA therapy, or is there a particular period like 3 months, 6 months, 9 months, or 1 year where you use a UDCA and then stop it? How do you sort of stop the therapy or increase the dose? Like you are giving a 300 DDS when the bill is high and transaminases is there. Now the things are controlled. Whether you want to continue the UDCA therapy, say LFT starts coming normal after 6 months. Now the patient comes with a normal LFT report and an INR of 1.2. I'm talking about very practical scenarios, obviously. And now you want to continue UDCA or you just want to stop UDCA, and what kind of therapy you want to give this kind of patients?
Therapy would be treat the cause, reverse the etiology, continue UDCA till the point you see inflammation. Inflammation is AST ALTs. If they have normalized, the cause is controlled, the cirrhosis is not progressing. There is no decompensation, there is no bleed, there is no HE, nothing. It's just a compensated cirrhotic. Controlled inflammation, I would stop there.
Okay, child age cirrhosis, which is now controlled by you. Patient, you told them not to drink alcohol, you gave a therapy 6 months now. He is now in a very controlled state. Do you expect them to progress, the fibrosis progress further without any kind of a therapy? Say we are not giving any UDCA or any antioxidants or something. What is your experience about it? Like how do they do after 2 years, 1.5 years, 3 years, once they are normalized with their LFTs? Whether they progress furtherly and suddenly present with a severe portal hypertension and ascites. In spite, I have seen many patients who have not taken any alcohol. They have told me, sir, हमने तो बिल्कुल छोड़ दिया. But suddenly they present with a portal hypertension or hematemesis one sudden fine day after 3 years, 2 years. So what is your take on that? Should we continue with any sort of medication, not about UDCA, any sort of medications during this cold period of the cirrhotic patients?
So the problem with continuing a drug is we don't know the end point. If suppose the patient is compensated cirrhotic, and you have controlled the primary causative agent, alcohol, viral hepatitis, you have treated them. If there is also associated other condition, like many of the alcoholics also have fatty liver disease, which is a subdue form of there. We are advising them, we are looking at one of the causes, but we are not looking at the spectrum. So you also have to look for other causes. Get their Hep B, Hep C done, immunize them. The reason why a well compensated patient decompensates, either it is going to be subsequent insult in form of MASH, or he has developed some infection to prevent getting, vaccinate them for A&E, vaccinate them for pneumococcal, prevent infection, any infection, UTI, LRTI, even slightest of the infection would progress. That is ACLF, no? Acute or chronic liver failure. That any insult will set in the cascade and then patient will decompensate. So you basically have to make sure the patient is well vaccinated, control the fatty liver disease, and if inflammation is controlled, they should do good.
One last question. Yes. A proven cirrhotic obese patient with diabetes. We have lot in India. Do you a proven cirrhotic, a grade 3, grade 4 diabetes, and say a BMI of 35, and proven cirrhotic total hypertension, you have done an endoscopy, you have done EVLs and all. Will you still recommend anti-diabetes, and he comes to sir with HbA1c of 9.2, he is giving a lot of medications, anti-diabetics and all. Will you still recommend to give this semaglutide or tirzepatide?
I will give tirzepatide. Because the thing is, I now want the patient not to decompensate any further. If the patient, there is no clear-cut indication. It is only approved till now for F2, F3 fibrosis. But if you know a result is there and patient has not yet decompensated in the form of ascites or hepatic encephalopathy, if he has gone to a stage of hepatic encephalopathy or a progressive jaundice, don't give it. If it is an ascites which is controlled, the progression of liver disease is then you would give it to bring down the weight.
Yeah, over dinner. Dr. Vipul, your question.
Good evening, sir. Thank you for such an informative talk. I have two tiny questions. One is, what is your choice of long-term GLP therapy when dealing with microinflammation, alcoholics as well as non-alcoholics? The other one is, would you generally add UDCA while patient is on GLP, or would you wait for GLP to act?
So my preferred drug is, I commonly tend to use tirzepatide. I have personally seen it gives a better weight loss. So although not recommended, if patient is obese, diabetic, non-alcoholic, I would go for tirzepatide. If the patient is non-diabetic, just plain MASH, obese, I would go for semaglutide, which is the preferred indication. And the other question was about UDCA. So UDCA, I personally don't give it for too long. I only give it in this phase I see necroinflammation, which is the arranged AST, ALTs, or if it's an advanced fibrosis, I don't see any use of that.
Dr. Tulsi sir.
Thank you, Dr. Chauhan. So, to answer Dr. Chauhan's question first, regarding semaglutide, has been approved in August 2025 for the treatment of NASH and MASH. Regarding tirzepatide, not yet approved.
Not yet.
After the Synergy NASH trial, they probably, I think it's a matter of time when they approve this drug. But Dr. Peeyush, what I know is there are just few drugs which really work in NASH. And first of all, of course, as we know, losing weight by any means.
Yes.
Then the role of metformin. See, you never mentioned what metformin. Then SGLT2 inhibitors, then GLP-1 agonists, and finally the new drug we talked about, resveratrol. So in the 2026 guidelines, regarding grading the severity of necroinflammation, they are now talking about portal inflammation as a part of the grading system. Your word on the portal inflammation.
Portal inflammation is again a biopsy-proven thing. Any inflammation, portal inflammation is dependent on the etiology. So if the cause is viral, it would starting from the portal circulation. If the cause is fatty liver disease or alcoholic, the inflammation would start from the central venule, which is not the part of the portal triad. So the type of inflammation is dependent, the site of inflammation, I would like to say, is dependent on the etiology.
So we have now newer imaging which are as good as the gold standard biopsies. He's talking about imaging. When I talk about imaging, it's about multi-parametric ultrasound with shear wave dispersion. Not to forget the MR elastography as well. Now the recent marker has been regarding the hepatic GST M3 deficiency for accelerated, progression. Not only that, it has, people who are deficient in this also augmented atherosclerosis. Talk us about this, the new marker.
I will have to read about it. You know more than me. So
I think that's all.
Thank you.
Thank you.
Friends, as I said, I have requested Dr. Seth Gupta and Radha Lakshmi to give us one song.